Tim McGrath, welcome to the Pacey Performance Podcast. It's a pleasure to have you.
Thanks for having me, Rob.
My pleasure. Thank you for accepting my invitation to come on the podcast. And more importantly, thank you for accepting my invitation to speak at our Return to Play conference in LA in June.
That's good. Any opportunity to talk about ACLs? I'm a big nerd when it comes to that.
You're in. Give us a bit of a brief overview of what that talk will look like in June.
I think, like, for me, the title we called is, so can they go? Which is obviously like the question that you get, particularly on the pointy end in sport, which is where you got someone who's obviously done a big injury like an ACL, and ultimately it's okay. When are they ready? How do we know they're good to go, kind of thing. So I think it's being able to kind of blend the art, which is on the pitch. All the sort of the nuances to how are they ready to perform, and then from a risk factor management point of view, from a rehab is really the go no go points, just to try to minimize the chance of something negative happening during the rehab. And I think that's having those those two sort of major themes in your brain all the time, I think is the bit that you're trying to achieve at the end of the day.
Nice, mate. I'm looking forward to having you. Should be good. Anyone who doesn't know who you are, would you mind just giving us a brief bio?
So I'm Aussie. So by background, I find myself needing, especially over here in the States, having people to interpret for me half the time, because I think half the time they can't understand what I'm saying. So so I'm Aussie by background, physiotherapist, by trade. First year in professional sport was 2004, and then more or less been sort of in it ever since. So sports that I've worked for across Australia, few short stints in the UK, and now over in America. So rugby league, the NRL, Super Rugby, rugby union, English Premiership, Australian rules football, and then in the NFL now. So my job is to kind of oversee the health and performance department. In 2016, as part of that, I finished a PhD on ACL. So it's really the blending of the two between everything from sort of 3D kind of motion capture, and then obviously trying to apply that into the clinical setting.
Nice, mate. What's the transition like coming from? Did you go from Oz to the US? You didn't go from the UK to the US, Oz to US.
Yeah, Oz to US. Yeah.
What's the transition been like?
It's amazing how like similar Australia and the US is, for example, but just how different a lot of things are. Even just the words that you use for things are different. So like, they're not boots, they're cleats. There's just different words for everything, and it's never more noticeable than things like when you're in a coaching meeting where you really don't have like forever to get your point across. So I'm a big analogy kind of guy. So like I love using some kind of analogy to sort of summarize the bits, the point that you're sort of trying to get across, is where I feel like I've had that superpower just completely taken off me over here, because half the analogies that I would use, no one even knows, what I'm even talking about. So I think that's probably been just the biggest challenge, is just getting on the same wavelength, from a communication standpoint. Culturally, things have evolved differently, like in the US to, like I would say, the time that I spent in the UK, it's more or less seamless. Like between Australia and the UK, I feel like they're very similar. Australia to the US is culturally, there's just the way the systems have evolved is quite different. So it's less about the technical part. Like that's the bits that the value that I think I've sort of tried to bring here is a lot of that sort of technical expertise, but it's then just kind of putting it into an overall system or a structure that makes sense to everyone over here.
When we did the speed conference at Pitt, summer 24, the amount of things that just baffled me or baffled them when it comes to communication. Yeah. Just for example, on the conference like schedule that we printed off, the booklet, everything was in the 24-hour clock to make it streamlined. Every time had 4 digits. Baffled. Why are you
Yeah.
doing it in military time, Rob? I'm like,
Yeah.
the friggin' hell's military time?
Yeah.
No, we do it. And on our phones, like on my phone, automatically, my iPhone is 24-hour clock.
Yeah. Same.
There, obviously in the US, it's not. It's, the 12, whatever. And I just, like the same language, but just so different.
Yeah.
So different. It's hilarious.
Yeah, it's actually amazing. And like it's not like me being here. It's not like the first time I've been in the US. So it was, yeah. It's when you're sort of in the trenches talking, where you have to get your point across really quite quickly. I think is where it becomes the most noticeable. So so that was definitely like a learning curve for me.
Yeah. Right. Let's dive in. So I know you've got interviews and things to deal with. So we'll dive into the ACL side of things that you're going to speak about in LA in June. So specific biomechanical or neuromuscular assessments that you think are essential for identifying athletes at higher risk of ACL injuries.
Again, I love, ACL is a complex injury at the end of the day, and that's why it gives people trouble. And so, again, I'm an analogy guy, and Ian McEwen's going to, his ears will be burning right now, but because he knows that I like to use analogies on things and thinks that they're ridiculous half the time. But for me, I use like a racing car sort of analogy, just to try and make it as simple as possible, where you've got the racing car and you've got the racing car driver. So in an ACL, you've got all the physical components: strength, power, mobility, stability. Like that's the racing car, like all the sort of physical components that help you with range of motion, ability to absorb and produce force. And then you've got the racing car driver, which is, high pressure situations, high velocity, those kind of at-risk movements. So, in different sporting environments, for the NBA, it's generally driving to the basket, fast turnover. In football, like soccer, it's strikers, it's when they've got the ball. Or if it's for a defender, it's when, the opposition's got the ball. If it's in rugby, it's generally very heavily tagged to when they're carrying the ball, jamming off the line, they're going to run and cut and step, high closing velocity, or if it's, defensively, they're trying to get off the line to sort of take up the space. So the racing car driver is really like those high sort of pressure situations. And to that end is that you need to have this cocktail of things that creates that high risk situation. So if it's a racing car driver and you're going 60 kilometers an hour around the racing track, you can have a blood alcohol of like 0.25 and you'll never crash the car, because it's not really testing that kind of feed forward sort of system. So it's really that where there's high closing velocity, big change of direction. And from the biomechanical sort of aspect of it, the bit that we've sort of learned is it really just comes down to three sort of big pillars, from a like a re-injury point of view, which is really like, how wide they are, when they're cutting or changing direction, how wide their foot is relative to their center of mass, how stiff and straight their leg is, so low knee flexion, like at the moment of sort of foot contact, and then the ability to sort of not attenuate things around the foot and the ankle, like I noticed with the conference in June, how one of the topics is around kind of foot and ankle complex, and that's one of the big things like managing ACLs is that it's a whole kinetic chain thing. So I'm a big fan of that. People that don't attenuate things at the foot and the ankle just go straight up the chain. And this thing that everyone sort of talks about, dynamic valgus, from a biomechanical perspective, is really this externally rotated hip and then an internally rotated kind of lower leg. So you get this kind of like pepper grinding sort of effect. And it's, if people in this sort of benchmarking process coming back, it's like how much cognitive rigidity do they kind of have? So in a high stress but low chaos kind of environment that a lot of these testing or rehab situations tend to be, is are they doing those things innately already? It's meaning they've got no margin of error once they get into that high stress, high chaos sort of element of sport. So it's the blending of the two is creating, so doing biomechanical testing, which people have been doing for years, but if you do it in a 5x5 area within a lab where it's not on the surface that you're talking about, there's no entry velocity, there's no real reactivity, like the information you get at that point, no matter how pure it is from a biomechanical point of view, you can't really use that because it's not testing that kind of feed forward sort of aspect.
So any specific assessments that you would use or you would want to use?
Again, it depends on obviously, like, it depends on the stage of the rehab that you're talking. So if it's mid-stage rehab, it is sort of more heavily towards the ability to absorb and produce force. Like from an ACL point of view, one of the where rehab fails is you just get an angry, swollen kind of knee, sort of, that return to run phase. So it's kind of like depends on the stage you're talking about. So in the pre-running phase, it's the ability of the knee to kind of load and unload itself. So even just looking at things like single leg squatting, the ability of the knee to tolerate compressive load. So for 1 unit of load, the more they bend the knee, the more compression there is across the joint. So having a knee that can tolerate compression, and then having it so it can unload itself at the same time, because a normal knee sort of goes through that full arc of movement. And if habitually they can't do that, then if that is allowed to stay through rehab, once they start getting into running, they start getting a sore, swollen knee, and it's just purely because they can't attenuate load away from the joint. So strength is obviously the biggest priority in the earlier phases. Then it becomes about that, concentric into kind of eccentric, strength, power, however you want to sort of define it. And then ultimately it's the skill aspect, which is where that, quantifying movement, that's where that sort of later part sort of comes to the fore. So it's really like you'll have a battery of testing, but I think at each time point is really where you want to have evidence of normality at the end of the day. So you see like people talking either like in the social media sort of forums or through research, and they're talking about people going back and they haven't normalized strength, for example, having like low isokinetic dynamometry. And for me, that's like so far off where they need to be. If they're at the point of talking of going back and they're still talking about strength deficits, like strength for me is like a mid-stage progression. That I want that fixed a long time before I'm even thinking about kind of putting them back into like a game situation, because it's ACL is as much a brain injury as it is like a physical injury at the end of the day.
Would there be anything that you do with your healthy athletes to look at those potentially at higher risk
from
an assessment perspective? Yeah,
again, like I would say it's a similar battery in the test, in the sense of you've got those two pillars at the end of the day. Obviously, a normal healthy athlete, a lot of those physical components should be sort of normalized. So it's really around unanticipated high speed change of direction is probably the pointy end of the stick at the end of the day. So normal athletes, where you're trying to pick out who are the ones that probably need some work-ons, who are going to be potentially more the higher risk, is really around high speed change of direction for me.
Would you do anything like Tom DeSantis' CMAS? Anything like that? Anything assessment based with video?
Yeah, I again, like everyone will have their own little way of it. For me, it's around like 3D biomechanics of change of direction. So like I'll just go right to that, which is where like that's where the normative database that we built is around. So that's probably what I know best, and so that's where I'll tend to go.
Cool. Just moving on slightly. So incorporating drills and movement patterns in training to reduce injury risk. Again, maybe looking at that healthier population. Where does that fit? What does that look like for you when it comes to specifically reducing the chance or the chance of ACL?
Yeah, I think you're talking about skill acquisition at the end of the day, right? And I think the danger is making too many assumptions about what someone is lacking. Like I like to think that I know a bit about this kind of topic, but you'd be surprised how your biases tend to play out just in real time, just watching people doing things. So having objectivity around what those components are is probably the most helpful thing. And because ultimately, from a skill acquisition point of view, if you think about your golf swing, you can't have 50 things that you need to work on with your golf swing, because otherwise you won't even like be able to swing the club like at the end of the day. So a lot of these things is about bringing it down to 1, 2, maximum of like 3 things that you're trying to sort of work on, and having some evidence as to why is that person doing that, and also then obviously the background of like why that is kind of important. But to that end is the drills themselves which is where the skill acquisition part comes into it, is like having elements of part practice just to try and, even if nothing else, to get the athlete sort of working on like that feeling of what it's supposed to be, especially when talking about skill acquisition. But ultimately, it has to go back into feeding into the actual environment. So if it's a rugby player, for example, that has to relate to, so if you're talking about change of direction and they're going wide of their center of mass or something, you'll have part drills to try and get them to sort of tuck that foot in, generating force close in underneath their body. But then ultimately it has to be fed, immediately back into carrying the football in, and you might modify some elements of the task to simplify it. So there might be, I really love, the chaos control continuum in terms of sort of managing that, where you will remove some of those variables just to simplify the task, but you're still practicing the task at the end of the day. So even within the rehab, I'll have people doing change of direction really, really early on in the piece. Now it might even just be walking change of direction because you're just trying to get the concepts down. Because on the back end of it, like I've said this a few times, I've had people where they've tested. There's things that are outside of a normal range you go work on. You start talking about a bank of drills you want to work on, and they come back 8 weeks later and like nothing has changed, like 0% of it has changed. And you go through the drills, the intensity, that's sort of like how I do it. But where the reason every time why it failed is predominantly the athlete had no idea what they were trying to achieve, and there was no sort of feedback loop around like what was good and what was bad about the like performance within the task. So ultimately, if you identify that particular theme that you're trying to chase, and you have 4 really experienced sort of practitioners, they'll all probably attack that program like in a slightly different way. And ultimately, I think all of them will probably do a good job of it. I think the key component to it is having that switch between part practice to like whole task, and then also athlete having an idea as to what they're trying to achieve at the end of the day. Because if they have no idea and there's no feedback loop around that's where it tends to fall over. It's less about the drill specifically, and it's more about having an opportunity to practice it and then put it into the whole task.
When you talked about biases then, is there any experience that you've had where you've been kind of taking yourself down a particular track because of your own biases, and it's led to you a place where you didn't want to be?
I think like,
or again, others, like, maybe.
Yeah, it's the ones that are a bit more subtle. Like, I've had people sort of talking to me about calcaneal position or pelvic position with different components to it, and it's just watching someone running on a video or something, and it's like how can you even prove that sort of one way or the other? So it's really like ultimately someone has an opinion of the world, and then they just see what they kind of want to see at the end of the day, and they have really and a lot of the ones that do that, it's like, well, like, prove me wrong. So it's the onus isn't on them to prove why that's there. They'll just say, they'll throw some concept out there and say that's what it is, and like, prove me wrong, as opposed to like the reason why they do that is because of this and this, and I have something objective to it. So I think that's really the like a pet peeve of mine, if I can say that, is really like they try and position it so the burden of proof comes on someone to prove them wrong, rather than them having something to hang their hat on to say that's what they're saying is right.
Do you think that's a global thing? Has that been the case wherever you've been?
Yeah, that's a universal. That's a universal thing, and it comes down to how passionate. Like, often the delivery of the information obviously dictates like how convincing they are sometimes. So it's people who are really good at it will do it they're very good salesmen. They'll say it in a way that is very convincing, and if you don't really know enough about the topic, you're not really quite confident enough to sort of challenge it. So that's a universal thing. As where the best practitioners that I've seen will have very clearly thought out reasons to why they feel that something is important or isn't important, and they'll have and they're good at making the complicated simple at the end of the day. They don't hide things behind complexity, because that's sometimes people try and use big words or big concepts just to try and make themselves smarter and almost like kind of fool people into where they're going. So as where the best ones actually they have this innate ability to make the complicated simple.
So across the clubs and across the leagues and countries that you've worked in, what are the biggest mistakes that you've made or you've seen being made in teams that are in and around you when it comes to dealing with ACLs or rehabbing ACLs?
I think it just comes back to which is how I tend to approach the rehab these days, is knowing where it can go wrong, probably at the end of the day. So,
What is that? What are them points, Tim, from your
yes,
opinion?
so so you've got at the most fundamental level is having a knee that is structurally not sound, so they can't achieve full knee extension. They've got a cyclops lesion, so they're trying to run. They don't have good range of motion. So the NRL sort of a couple of years ago, the guy was trying to run and he had like 15 degrees off full extension and 90 degrees of bend. So it was like he was trying to run because like the time period said that he should be running by now, but it was like he had a flat tire kind of thing. So there was just this. And he just had all this scar tissue in his knee that, so everything else that follows on from that wasn't going to work. So you've got that, at the most fundamental level. Then you've got, I've had ones where they're failing that return to run. They get like an effusion or they get a sore knee. And it's just purely because that they didn't have that strength quality in the build up to it. So the knee, ultimately, too much of the load was being absorbed at the joint, not away from the joint. As part of that, we talk about, arthrogenic inhibition, which is a big problem, like post ACL. So you just get like the leg just won't work because it's become sort of dyslexic, from a strength kind of perspective. So, the vulnerability that can come from that is, if you have a meniscal repair or something where that requires like a period of it's a long initial period of protection. That's where the vulnerability to that sort of increases. So that can become really hard. So from getting the leg going, often it becomes about high volume work rather than like, because you're trying to wake things up and just get the brain to understand, as opposed to like traditional strength things where you might do 2 exposures in a week. That will never work in that environment, just purely because they just can't get the leg going. It's a motor control issue at the end of the day. So, so that they're some of the more earlier sort of issues. And then after that, it's really like, for me, it's like risk factor management. So I keep coming back to the pointy end of the stick, which is where like ultimately where is the high risk for that athlete? Like if they're a basketballer, it's, there's going to be vertical components. There's going to be closing with change of direction. And it's really about trying to manage those risk factors as much as humanly possible. So it's ability to absorb and produce force and having evidence of that, and not wait. If you're waiting till that being at the end of the rehab, you've missed the mark. You needed to be going more aggressively with that earlier. And then the final hurdle within it is always this motor control sort of aspect. And because if it was just about, I think the mistake that we tend to make is, if it was just about absorbing and producing force, and can they jump on a force plate, we just turn everyone into a powerlifter. As long as they can deadlift, 350 kilos, then they can go and play in the English Premier League. Is where, the reality is that's not how it works. Is strength is a tool that the body uses to absorb and produce force, but it's how it all kind of puts it all together is really the final step in it. And then the last bit, which is, I think, fear is something we talk about with this, and there's a lot of things on the back end where you can all the physical components can be well addressed, but in the end, they do not have confidence in that leg whatsoever. So when they're going to change direction, that the body almost does everything that it can to avoid putting that leg in positions of stress. So everything they do from a functional sport sort of level is geared towards avoiding that leg, and then that can create problems too. Like it's I've had I remember like Australian rules, one of the they sent me this player, and you're watching him change direction, and instead of like changing direction off that leg, he would just crossover cut every time. Like he just would refuse to plant, so he'd sort of like initiate it from the contralateral step, kind of like push across, and then so that then the other leg almost just kind of like follows through. So there's no real mechanical stress on that. And talking about it going like, has he got any problems like on his other side? Because he's just doing everything on that side. Yeah, he's got this hip impingement that he just cannot shake, and he's had injections, and he's had this, and he's had that, all these issues, and they can't shake it. And I think the earlier version of me would assume that there's a problem with the hip and I've got to do something to the hip. even like hip scopes or something, because you just, they've gone through that progression of rehab, injection, still not working. So it must be like a structural sort of issue. But then the older version of me is, okay, like where's the threat coming from? So it was like, okay, try and get it so that as part of the ACL, get this good to actually decel like on the ipsilateral side. And like I think it like cleared up in like 4 weeks, like something really dramatic, just purely because as soon as the threat was taken off that side and it was a bit more of a balanced sort of a task, like less cognitive rigidity probably on that injured side. So fear can take like on multiple levels, which is where it's like you feel like you haven't done the work, but also like you just don't actually, at the end of the day, you just don't trust the leg yet.
I feel like I put you off on the initial question by asking you about points of failure. Anything you wanted to add on mistakes? Any of your mistakes or people around you's mistakes, team mistakes?
Yeah, like I think you'd have an hour to cover off on all the mistakes I've made. Like the specific ones that I've had where I've addressed the functional parts of it really well, but like the biological components weren't handled very well. Like I've had ones where they've had like a partial injury on the ACL and then never checked it again, like with imaging as they progressed. So they ticked off all the functional components, then had an instability episode sort of down the track, just purely because they had no ACL. Like at the end of the day, like structurally the thing wasn't sound. So it's like, I don't know how to summarize it really quickly, other than just like having this checklist of things that can go wrong, and it's everything from stability of the knee, range of motion to the knee, that strength and power sort of aspect, and then the skill relating to those injury mechanisms. And I'm just trying to make sure that I've addressed all of that at each kind of stage, and then setting it up for the next particular stage. So it's having strength means that when they start going into linear running, that they that the knee is happy when it starts getting into running. So the mistake I've made there is they start running and they get a sore knee because they didn't give it a good enough base in the build up to the strength of it. The next stage is they get into linear base and I start getting into change of direction. And I've given even though I'm linear accumulation from a volume point of view, but I haven't done any work on, trying to get some of those easy motor patterns in terms of change of direction. So I have to, rather than just being able to train that with intensity at the next stage, I have to start, like I'm delaying the process because I didn't address it back there. So I don't know any other way to explain it other than just like having this like systematic process and knowing for each of those rehab themes, making sure that I'm in the phase before that I'm setting it up so that it's, that it's checked off from that point of view, so you don't have a setback once you get to that next phase.
Let's talk about the latter phases, because I'd like to ask you about how you objectively determine where or whether an athlete can move on. Is there any I know we kind of touched on this at the start, but I just like to get into the weeds a little bit more and what you actually would do either there or elsewhere where you've been.
Yep.
So objectively assessing the athlete in those latter stages to make sure that they can either progress to full training or progress to the next stage. Could you tell us your thoughts on your kind of practices on those points?
Yeah, so like from a benchmarking point of view, like around that sort of 70% mark, subjectively when they're sort of doing change of direction and kind of like 70%, that's where we'll probably go down that formal path of sort of assessment. So it'll be clinical baselines, it'll be stability. So we actually measure like the laxity of the knee, and I just use a KT1000. There's different versions around through there. Some people just do manual assessment. So at the end of the day, you've just got a happy sort of functional kind of knee that has good range of motion. Strength-wise, again, you want it to be pretty well normalized, but I'll just get people to repeat single leg squat off a 50 centimeter box. And when I did my PhD, I did isokinetic dynamometry to death, and I found like single leg squatting just being gives you every bit of information that you need. The elements of isokinetic dynamometry that I didn't feel like I needed. So just repeat single leg squatting shows that the knee can tolerate compressive load. You're trying to get them to around sort of 105 degrees or more. It demonstrates that the knee can tolerate that compression, so that any weakness at that point is about rates of force development rather than like true strength, the knee being able to sort of tolerate compression. As part of that, you look at their terminal knee extension at the top of it. So if they're off-ending extension, so normal is around sort of 0 to 5 degrees, or sometimes they get into hyperextension. So if they're not doing that, then that can be like that inability of the knee to get to that sort of unloaded position. And the clinical baseline sort of element, if they do have full range of motion, but they won't do it, actively, that's an active deficit as opposed to it being like a range of motion deficit. And then climbing up the totem pole from there would be plyometric. So the ones that I'll tend to do is drop jumps, so single leg. I won't worry about double leg drop jump. And again, you're looking at that ability to absorb and produce force, but again, looking at those feed forward mechanisms. So at time of foot contact, what position is the ankle? What position is the knee, sort of predominantly? And then because stiffer, straighter leg means that they're being really passive about how they're absorbing it. So from the beauty of biomechanics is you can look at that in minute detail, and you can also look at from time of foot contact to peak knee flexion, so that if they're lacking that sort of reactive strength, they'll either land in a stiffer, straighter position, or they won't actually the net change across the knee from foot contact to peak knee flexion. So, roughly about 18 degrees or more is about normal. So, ones will, they might land in a bent knee, but they don't have that shock absorbing quality. So they'll only change like 5 degrees, for example. And then you'll have them where they get into terminal knee extension. So they have the ability to unload the knee, same as like you did with single leg squatting. For horizontal, I'll do cross hopping. And with a lot of the testing, I don't get didactic about hands on hips and all of that kind of thing. Like for me, it's jump off the box, get off as quick and as high as you can. If it's cross hopping, it's like they don't have to stick that last landing. There has to be heavy decel at the back end of it, but it's really like just jump as far as you can, because the biomechanical aspect of it is we're looking at that kind of mid landing through the cross hop, where they're sort of landing and then producing force again, because you're looking at that same qualities as what you did with the vertical at time of foot contact and then peak knee flexion, and then looking at those risk factors that we were talking about sort of before, and also like from a knee function point of view, like can the thing load and then unload itself, and then change of direction wise, it's unanticipated change of direction. So we get people to gas in over a sort of a 10 to 15 meter wind up, have a reactive sort of a 45, change of direction. And then again, the cue is we put them in a volume with the 3D system, and it's really like just see and go. So I'm not putting them on, making them step on a force plate, like trying to constrain it. It's literally like I'm just trying to create stress by getting them to go as fast and react as quickly as they can, and then looking at it, penultimate step, change of direction step, and then step after. So penultimate step is, do they heavily try and wash everything off on the contralateral side, particularly when you're talking about the stepping on the injured side. Change of direction step is at time of foot contact, ankle, foot, hip, particularly in pelvis. And then those big risk factors, so foot wider center of mass, stiff straight leg, and then that sort of pepper grinding effect kind of around through the hip. And then ultimately, from a validity point of view, is the change of direction, they have to have high entry speed. So again, if they're coming in at 5 meters per second, everything else is useless after that. So if they come in slow or they don't really change direction, I don't tend to listen to that data too much. As where if they're coming in hard, big change of direction, then okay, that's more likely, testing that sort of feed forward kind of aspect. And then you're looking for common themes across the board at the end of the day. So like if someone is doing something vertically, horizontally, and change of direction, there's no it's more likely that that's their preference for how they like to do things. So from a methodology point of view, again, like especially when we start talking about biomechanics, you have to get through learning effects. You have to make sure they understand the task, because you need the data to be clean. And you need to have enough reps to wash out individual variability across the task. The danger that happens with a lot of screening is they'll get one rep across one task or something like, and then try and make assumptions about what someone kind of does. So there's some nuances to the actual methodology as well.
What's that cross-hopping protocol?
So cross up. So you've got a straight line, and then they'll go. So they'll start. So if it's a right leg, they'll start on the left hand side, and they're going 1, 2, 3. So triple hop for triple crossover hop. PhD, I did a battery of all 4 of them at the same time. They all tell you pretty much the same thing. So I just go. I want to have like diverse themes. I want to have vertical. I want to have horizontal. I want to have change of direction. And the reason I pick cross hop is at least on that sort of insight. So they're going like 1, 2 before the last one. From a biomechanical point of view, they've got the most momentum behind them, and they're in the most awkward position of like the whole movement. So from a biomechanics point of view, that's a way of sort of teasing out what that leg is trying to do.
And what are you looking for there in terms of metrics?
From a biomechanics point of view?
Yeah. Are you because you're doing a 3D motion capture, aren't you?
3D motion capture, yes.
Okay.
So you're getting foot and ankle position, knee position, hip position, pelvis position, or at time of foot contact, and then those same things for at time of peak knee flexion. And then like we had to build like a normative database. So then everything is referenced to, you've got the middle of the bell curve for each of those components. So I think there's about 80 metrics in all once you pile them all together. And what you're looking for is variances from the norm. So from things that you jump up and down about is the error of the measurement, is somewhere around 2 to 5 degrees from like a marked sort of capture. Because that's the other part that gets into it is the reliability gets worse depending on what you're talking about. So marked capture versus markerless versus like 2D sort of motion analysis. Like you just have to know the strengths and weaknesses of that as well. So everything for me is like, this is the middle of the bell curve from population norm, and then looking how far outside that, how many standard deviations across.
If you didn't have 3D motion capture, would your decisions change on what you do?
I think you just have to know what the things that you can't see. So you can see, especially if you've just got video, like you can video from perfectly perpendicular for change direction. You can look at, are they on their heel? What's their sagittal knee bend position? You can video things where you're going from frontal plane, like roughly how wide. But at the end of the day, it's all qualitative at the end of the day. So there are plenty of things that you can see. But some of the more important ones are really quite subtle, and you can't. It's really hard to see that with even on just basic sort of video analysis. And like I said, if it was that simple, I wouldn't even bother with some of these things. I'd just pull out a GoPro and then video things, and that'd tell me everything that I need to know. So it's hung around just purely because there are plenty of things that you just can't see without that technology. Do
you guys in the NFL get a particular system? Or you're on your individual deals?
Yeah, so everyone's got their own sort of individual deals. So like again, like I use Vicon because that's that's what I'm sort of familiar with. Different places sort of will embrace markerless. So Dari's around and some of those different ones. Again, there's strengths and weaknesses to all of them. The marked one has a bit more reliability in terms of the test retest sort of components to it. And you can see more things, but obviously it means you've got to marker someone up, and it constrains the task to what you can do. Is where some of these other markerless ones, you can put them a bit more in their natural environment, but just the range of metrics you can look at, is just going to be narrower. That's all.
I've got one last question for you before I let you go and get to your interviews and things. 6-month return timeline. We had an article on this of the accelerated rehab from an ACL. What's your thoughts on this?
Yeah, I have done plenty. Even like now that I'm, I can look at lots of different components from a re-injury risk, and we've even in that era we've had people come back at 6 and 7 months. I think the reality is time is just a function of how long they've been in the rehab. So at the end of the day, I don't subscribe to it has to be 12 months or 9 months or 2 years. I don't subscribe to that at all, because I think from a biological perspective, once they, the further they get it, the difference from a biological perspective from 6 to 9 to 12 is a diminishing component. And I've had plenty go back at 6 and 7 and have no problems. It's really like that, like I said, all those pillars of risk mitigation, and then having enough time to then integrate them back into their sport and dealing with the chaos and not having cognitive rigidity like from a performance sort of point of view. So the reality is it's hard to get all of those things done well in that time span. So I think that's more the challenge, is getting everything in, as opposed to it just being it has to be 6 months, or it has to be 7 months, or it has to be 9, or it has to be 12. And for a while there were people banging the drum a lot, that it has to, do not go back before 9, or do not go back before 12. And a lot of those things have been proven to be, not true, just purely because it's missing the point, is that time is a function of rehab. And the longer you're in rehab, the more opportunity you get to deal with some of these things organically, but in itself guarantees nothing.
Amazing. Right. I'm leaving you 9 minutes, but I'm just going to say thank you for coming on. Really appreciate you squeezing me into your schedule. But if anyone wants to come and listen to Tim as well as an all-star lineup, 27th to the 29th of June, Intuit Dome, Tim's selling it out in LA. So come along. But if anyone wants to get to know more about you, Tim, where's the best place? Are you a social media guy or not?
Yeah, I am. I'm a little bit more old school though, but I've got LinkedIn, and I've got X or Twitter. I tend to use those more than anything else.
Nice. And your work, PhD and things, ResearchGate?
I'm not as active on that, no.
Okay. So
yeah, as in like there'll be. I mean, most of the stuff like the Pitch Ready website, like the references are on there if people sort of want to find like the things that we published. I'm sure there is things on ResearchGate. I'm just not as proactive at managing those things.
No, that's fine, mate. All good. Right. Thank you very much. I'll let you get to your interviews. Appreciate your time, and look forward to meeting you in person, which is a rarity for me, for people that come on the podcast in June.
Awesome. Looking forward to it.
Thanks, mate.